Namaskar, dear viewers. Welcome to today's session of Young India Intensivist webinars. And today we have a very special guest, Dr. Manoj Goel. So, sir is a renowned figure in pulmonology and especially interventional pulmonology. And today he'll be talking on bronchoscopy in the ICU. So, Dr. Manoj Goel is Principal Director and Head Pulmonology and Critical Care, Fortis Hospital, Gurgaon. He is the author of very aptly a book on bronchoscopy called Bronchoscopy in ICU, a Practical Guide. He holds regular workshops on bronchoscopy, amongst other things. He's the principal investigator for Convidoc trial published in Lancet and the LifeNox trial published in NEJM. He's been awarded with the ICCM Chairman Award, and he's member of several expert committees and has organized various conferences during his career. So indeed remarkable, sir, and I think it's very appropriate that we should hear about bronchoscopy from you in the ICU. Over to you, sir.
Thank you, Dr. Tapesh. It's a great honor, privilege for me to be here with you on this wonderful platform. And I'm very grateful that you've asked me to speak on this topic, the bronchoscopy in ICU. And let me tell you that this is a huge topic. I mean, it's very difficult to cover it in 30 to 40 minutes time because you can do a 2-day CME on bronchoscopy in ICU. So what I'm going to do is to give you a broad idea about bronchoscopy in ICU, especially for the beginners. And those who are, going to work as a president or as a specialist in intensive care unit, and especially if they are from the anesthesia background, who do not have any prior exposure to bronchoscope. So let me share my slides. I hope the slides are on now.
Yes, the slides are there.
Okay. So, we started training the critical care specialists, or I would say enthusiasts, way back in 2009. And we were the first, perhaps in the world, to start, training programs in bronchoscopy in ICU under the banner of Indian Society of Critical Care Medicine, especially the Delhi chapter, where we used to, have this annual conference of DCCS. And then I, came up with this idea and spoke to the organizing committee. That time, Dr. Rajesh Chawla was at the helm, and then we started this program. And then this concept has come in a big way. And as a matter of fact, now bronchoscopy is a very important intervention, or which every intensivist should know. And this is not something that is to be left to the pulmonologist all the time. But yes, majority of time, when an intensivist should be able to perform bronchoscopy in critical care setting. So just to introduce a little bit, as I said, bronchoscopy has become an essential tool for diagnostic and therapeutic purposes in the modern intensive care unit. And virtually all the intensive care units now have their own bronchoscopes, and sometimes they also have the disposable bronchoscopes available. The good thing is that bronchoscopy can be done even in unstable and ventilated patients. Those who are high-risk patients, you can perform the procedure quite safely with little experience and care. So bronchoscopy is useful for massive hemoptysis, removal of foreign body, laser therapy, dilative strictures, and placement of stents. So you can do advanced bronchoscopic procedures using rigid bronchoscope, which should be left to the trained pulmonologists and interventional pulmonologists, because this is not the domain of the intensive care specialists. So actually, those who are beginning this intervention and learning this intervention, and also those who are trained in bronchoscopy, should leave advanced procedure to the pulmonologists, because they are more experienced and they've got more practice, more conversant with the advanced procedures. So you should know your limit as to where you have to stop and ask the help of the pulmonologist. The various bronchoscopy procedure that you can do is brushing if there is an endobronchial lesion, like if there is a tumor there, or if there is a mucosal overgrowth, you can do a brushing, which is not very difficult. Protected specimen brushing, we have been talking about for the last 40 years, but it's really not picked up, and I'll touch upon this later. Then bronchial lavage, which may be done as a therapeutic procedure and also for diagnostic procedures. bronchial biopsies, which generally would include a transbronchial biopsies. And then you can also perform transbronchial fundamental aspiration cytology. But I would suggest that for intensive care specialists, the bronchoscopic lavage, right, that should be their main aim of while doing the procedure. The rest of the procedure should be left to the pulmonologist, because if you're attempting a transbronchial biopsy, it can carry a very high risk, especially in the intensive care unit, and it's better that you ask more experienced people. So once you're doing simple bronchoscopies and performing only bronchial lavage, that should be your aim of doing bronchoscopy in ICU as an intensivist. Now, handling the equipment, bronchoscope, is a delicate instrument, and it's a fiber optic video bronchoscope most of the time, and it costs huge in lakhs, and therefore you have to, take care of this equipment very, very carefully. You must be aware of the parts of the instrument and the necessary accessories. You must be fully aware of the method of sterilization, very important, because bronchoscope is not sterilized, and it can cause spread of infection. You must be aware of the post-procedure cleaning protocol, storage, and maintenance of the instrument. So if you're venturing into bronchoscopy, first learn this. This is the stepping stone in the world of bronchoscopy. So until you're able to, look after your equipment, there's no point going ahead using this equipment. So what should be the choice of instrument in bronchoscopy for bronchoscopy in intensive care unit? I think 4.9 mm should be the ideal one, because it can be easily passed through tubes within a diameter of 7 millimeter and above. And it has a reasonably large 2.2 millimeter working channel, so that suctioning and also using accessory is not a problem. So this is good enough bronchoscope. Otherwise, we have variety of bronchoscopes with us in our bronchoscopy unit, starting from 3.1 mm to 6.9 mm, and various specialized accessory instruments are there. But for ICU care, you can't afford to have too many bronchoscopes. 4.9 is generally good enough. And you can perform a good diagnostic and therapeutic work using a 4.9 mm bronchoscope. What should be the choice of the endotracheal tube if the patient is on ventilator? The outer diameter of endotracheal tube should be of at least 2 millimeter larger than the outer diameter of the adult bronchoscope. So that's why now 4.9 mm is good enough, where even if you have an endotracheal tube of 7 mm, you can easily negotiate it. But it's better if you have a tube of 8 millimeters, because that makes ventilation easier. The other complications, in terms of the hemodynamic compromise, the lung mechanics, they can be minimized if you got at least 8 millimeter size endotracheal tube, but 7 may still be good enough. And if you have got a 7 mm tube, there is no need to change to 8 millimeter size tube. But if 8 mm is there, that would always be better. Now, coming to the person, besides the bronchoscopist, preferably 2 skilled assistants are needed to safely and efficiently perform the procedure. One of the assistants can help with administering local anesthesia, sterile saline, and should also be able to handle the forceps and other accessories. But important thing is the other assistant who should be monitoring the patient continuously. So continuous monitoring of the patient during the procedure is extremely important. So while you are doing the procedure, more focus on the patient and doing the procedure, but the monitoring has to be done by somebody else. But as a bronchoscopy, you should also be keeping an eye how your patient is doing, and you should be able to judge his clinical status while doing the procedure. Now we have to understand how bronchoscopy in ICU is different. Now, bronchoscopy can cause variable intensity of pathophysiological effects in a patient who is on ventilator, especially. So it can, alter the respiratory mechanics, gas exchange, hemodynamics, which can be of variable intensity and could be, significantly abnormal, which can cause, severe complications and morbidity and death. So that is something you have to be mindful of. So coming to the respiratory mechanism, there is a possibility of increase in airway resistance and decrease in compliance in these patients, and this is not uncommon, especially if the patient has got a ARDS. Then the positive end expiratory pressure can rise as high as 25 centimeter because of impedance to expiratory flow, insufficient time for complete expiration, and rise in functional reserve capacity by as high as 30%. So These are patients whom, bronchoscopy is being planned. As you can see, the fire to increase to 100% is a case of ARDS. And you can see the peak pressure is 39, and he's generating a tidal volume of, say, 346, the exhale tidal volume. So now this is a patient whom you're attempting a bronchoscopy, and this is what happens when the bronchoscopy is introduced. You find that the patient is going to apneas, the P max goes up to as high as 57, and the tidal volume decreases to 109. So these kinds of lot of respiratory, mechanical, and ventilatory derangements can occur while doing a bronchoscopy in a ventilated patient. The blood gas exchange abnormalities can occur. There would be fall in PO2 level, which could be quite significant, and there could also be rise in PCO2, which may again be quite significant. Now, there are various causes of gas exchange effects during bronchoscopy, because during suction, you are also sucking the tidal volume that is delivered, and which may be reduced to 200, 300 ml. There may be alveolar closure, collapse. The patient may go into reflex bronchospasm, and there could be leaks around the valve through which you pass the bronchoscope. So there could be many reasons for causing, hypoxia and hypoventilation while doing bronchoscopy. Then when you're performing ball, there is a decrease in exchange surface area due to fluid lavage. You're putting a lot of fluid inside. And already if the patient has got ARDS, his gas exchange area is compromised. And BAL also causes inflammatory response with the release of the various inflammatory mediators. But fortunately, majority of the time, these gas exchange abnormalities slowly return to the baseline from about 15 minutes from normal lungs to several hours for severe parenchymal disease like ARDS. There may be also hemodynamic effects. There may be increase in cardiac output by as high as 50%, tachycardia. And again, it's attributable to various factors like reflex sympathetic discharge, hypoxemia, hyperventilation in terms of the elevation of PCO2 levels. So all those things can, cause the hemodynamic compromise. There may be variable increase in mean arterial pressure and mean pulmonary arterial pressures in the ventilated patients, again because of the various reasons. There is a lot of evidence, there is increased intracranial pressure, especially if the patient has got a head injury or the CVA. And this is something that you have to be mindful of, especially if the patient has got a head injury or something like that. Coming to indications, important thing is that about 65 to 79% of the bronchoscopy in ICUs are performed on patients on mechanical ventilations. And if you are a beginner, it's better to start, doing the procedure and learn these procedures. In a patient who is on mechanical ventilator doesn't have too much of hemodynamic compromise. The lung mechanics are quite good, stable. The airway pressures are not very high. His oxygen requirement is not very high. So these will be the ideal cases. Under supervision, you can start learning the bronchoscopy. And about 47 to 75% of the bronchoscopy performed in ICU are for therapeutic purpose. And when I talk of therapeutic purpose, the majority of time it is for the collapsed lungs or atelectasis. So that is the main reason we want to do a bronchial lavage to remove any secretions or mucus plugs or blood clots. So those would be the main therapeutic indications. So coming to the diagnostic bronchoscopies, the indication would be pneumonia, especially if there is an immunocompromised host or nosocomial or ventilator-associated pneumonia. Important thing is that you don't want to do bronchoscopy in every case of pneumonia, right? And I'll touch upon this later on. But if the patient is immunocompromised, then try to do an early bronchoscopy because they have got a multimicrobial pathology, and sometimes it could be inflammatory also. So in immunocompromised host, it's very important to do early bronchoscopy for diagnostic purposes. Hemoptysis, again, if you want to localize the site of bleeding, hemoptysis could be an indication. But if there is a massive active hemoptysis going, it's better to avoid doing a bronchoscopy in such patient. And if you want to do it, it's better to intubate him and then do it. Because during bronchoscopy, the patient can bleed heavily. And again, if patient has got hemoptysis, it's always better to ask your pulmonologist to do a bronchoscopy rather than you go and do a bronchoscopy because you won't be able to do anything. Majority of time, hemoptysis can also be, managed at the same time by a trained pulmonologist. Diffuse or focal lung diseases is another indication. Generally, in ICU patients, we don't do diagnostic procedure in these patients until it's something like acute phenomena, like immunocompromised stores where there is a bilateral pneumonia where the nature is not clear. Then only you will do it. If somebody has got localized wheeze or stridor, where there is a possibility of a foreign body, or there could be a tumor, or there could be a blood clot, and which has led to collapse of one side of the lung, then possibly you can do that. Problem is with the endotracheal tube, for example, tube obstruction, malposition, again, a bronchoscopy may be indicated. Then evaluation of prolonged intubation and tracheostomy, sometimes they can result into tracheostomy fistula and bronchopleural fistula. So those are the possibilities which can be there. And airway injury secondary to inhalation of toxic gases, blunt trauma, and post-intubation. Then bronchoscopy is a good instrument to understand what kind of injury it is there, whether it's a stenosis or there is a bronchopleural esophageal fistula. So those things can be, diagnosed easily. The basic therapeutic bronchoscopy indications would include airway management like difficult intubation. So you can do a bronchoscopy guided intubation in difficult airways. Then it says, as a rule, you use bronchoscope while performing the percutaneous tracheostomy as a control and guide while doing the procedure. If there is a lobar collapse or atelectasis, then therapeutic bronchoscopy would be indicated. These would the cases, majority of time you'll be doing the bronchoscopy. And if there are some excess airway secretion which patient is not able to clear off, then you can do a therapeutic bronchoscopy, especially in patients COPD or cachexy patient, or maybe those got a neuromuscular disorder, then the bronchoscopy may be required. But majority of therapeutic work would be for collapse and atelectasis. But I tell you, your bronchoscopy would be mainly for a collapse which is due to a lesion, pathology in the lobar bronchus, or maybe a central airway obstruction. But if there is atelectasis due to the peripheral lesions, like in a patient who is bed-bound, obese patient, where there is no endobronchial secretions and that like is only peripheral. In those cases, the physiotherapy would work better rather than your bronchoscopy, because here your bronchoscope will not be able to do much, as a matter of fact. Coming to contraindications, absolute indications would be the inexperienced bronchoscopies and personnel, inadequate facilities or equipment which is there. So, of course, these would be the absolute contraindication. I would always suggest that bronchoscopy is a teamwork. So you have to have your team, and team does not include, one proceduralist and couple of assistant, but even the nursing, aides, were they the GDAs, they are also part of the team. They know what is their job and what they have to do. The relative contraindication would include acute myocardial infarction or unstable angina, especially within 6 weeks of the procedure. Worsening asthma or status asthmaticus can produce, reflex bronchospasm, which could be lethal. Coagulopathy and bleeding death is again very important indication. So sometimes, we are asked to do a bronchoscopy in a patient who is bleeding. And when we put the bronchoscope, in fact, the bleeding in fact increases, because as the bronchoscope touches any part of the mucosa, bronchial mucosa, it causes more bleeding. So in coagulopathy and diffuse bleeding, the bronchoscopy really doesn't help, as a matter of fact, where you have to treat coagulopathy and the cause the coagulopathy. So that is important. So not every case of bleeding you would put a scope inside. In fact, can make the situation worse. Thrombocytopenia less than 50,000 would be a relative contraindication. If you're doing a simple bronchoscopy, the platelet count may be as low as 10,000 is good enough. But if you want to do a biopsy procedure, then you need at least more than 50,000 of platelet count. Severe uremia, severe disability in the patient. Again, these patients are at higher risk, and where it's better that we ask a trained pulmonologist to do a bronchoscopy. So in a patient who doesn't have an airway, who is not on ventilator, who is relatively sick, and it's high risk, better to ask a pulmonologist to do it rather than you venturing into it. So I mean, these are all relative things. It all depends upon your confidence and your training. Otherwise, it's better that sometimes you decide person who can do a job better than you should be asked to do it. So coming to pre-procedure preparation and tests, obtain informed consent, adequate installation of the bronchoscope has to be ensured. You must have the ability to mucus trap, biopsy bottle, slides, personal protection with mask, gown, cap, goggles, and lead apron if required, especially if you're needing, fluoroscopy. KY jelly, which is not very commonly available, or a silicone spray, we generally don't use it. Nowadays we use, and because the KY jelly is not freely available, so we can use 2% lignocaine jelly for lubricating the bronchoscope. Then saline has to be there, and you have to have a crash and resistance trolley, which is always there in intensive care setting. So now getting started, ensure a clear diagnostic therapeutic indication of bronchoscopy. Do it only if it is really required and it's going to, change the approach to treat this patient from the diagnostic point of view and the therapeutic point of view. So there has to be clear diagnostic therapeutic indication. It's better that you discuss this with the team, with the radiologist, whether it was the bronchoscopy really going to help. Review recent imaging. So there at least a recent chest X-ray has to be there before the procedure, right? Ideally a CT scan, but a chest X-ray on the day of doing a bronchoscopy is extremely important. The plan of procedure must be discussed among the teams. As I said, it's a teamwork, so everybody should know what is his job, what he is to do. Be prepared for handling the anticipated complications. So in a patient, you first discuss what could be the complication. You should be ready for that. Okay, that is extremely important. Suppose you're doing a bronchoscopy and the endotracheal tube is not handy, then I think it's a criminal. So those complications, whether it's the breathing complication or there could be airway problem, whatever, risk of pneumothorax, the chest tube has to be ready. So all those the complications should be anticipated and must one be ready for that to handle. Coming to nil oral orders, stop enteral feeding at least 4 hours before a semi-urgent procedure, which is a bronchoscopy. So 4 hours is good enough where we want to give a light sedation. In case of emergency procedure, empty the stomach content prior to the procedure by nasogastric tube aspiration. You can do it, but 4 hours nil orally is the one that is recommended. Medication trolleys should have topical agents like lidocaine 1 to 2%, sedatives and hypnotics, which generally includes midazolam, fentanyl, propofol. Morphine we don't use. We as a pulmonology use only midazolam, fentanyl, but if we need to do a propofol, then we take the anesthesia backup. Short-acting neuromuscular blocking agents like atracurine and vacurinium may be required, especially the patient on ventilator with endotracheal tube. If the patient got a tracheostomy tube, TT, then you may not paralyze them. But in a ventilated patient with endotracheal, it's always better to paralyze them because these patients can sometimes bite the bronchoscope, which is very expensive. So that is important. You must be ready with hemostatic agents like ice saline, epinephrine. Should a bleeding occurs, and tranexamic acid can also be handy if as a hemostatic agent, which you can instill, endobronchially through the bronchoscope. Monitoring is most important during and after the bronchoscopy. In-depth monitoring includes blood pressure monitoring, which may be invasive, and majority of patients are invasive blood pressure monitoring, pulse oximetry, electrocardiogram for heart rate and rhythm, ventilator parameters like tidal volume, minute ventilation, peak inspiratory pressures. So all those things have to be monitored. So there are various parameters, various vital parameters that have to be monitored. Ensure adequate sedation, use of neuromuscular blocking agents as needed. So as I said, neuromuscular blocking agent you would use in patient who is on ETT, extremely important. And adequate sedation is important because that will help you to do the procedure nicely, will minimize the risk of any respiratory mechanical derangements and hemodynamic instability. The sedation helps to protect the fragile bronchoscope from possible damage due to inadvertent patient bites. Extremely important. So patient has to be sedated appropriately. Paralysis, I said, invariably almost absolute must if the patient is on ventilator with endotracheal tube. Use of nebulized bronchodilators is generally not recommended, but if the patient has got a COPD and asthma, it's better to nebulizing with bronchodilators and maybe with inhaled corticosteroids, so that we can prevent any inadvertent bronchospasm. So, but otherwise, routinely the nebulized bronchodilators prior to the bronchoscopy is not recommended. Always important with the patient on ventilator to increase the 5 to 100%, at least 5 to 15 minutes before, during, and for sufficient time after the procedure. Always ensure oxygen saturation greater than 90% at all times, especially if the patient got a cardiac comorbid conditions, right? So that's extremely important. Never allow a patient with cardiac comorbidity to, desaturate below 90%. Okay. Oxygen saturation again is important. Post-op bronchoscopy is SpO2 falls to less than 90%. It's better that you withdraw your bronchoscope and allow the patient to ventilate. And then once his saturation comes to an appropriate level, say 95, 96%, then you put your scope again. Except when the patient has got a gross hemoptysis or has a collapse where your procedure can in fact improve the oxygen saturation very quickly. So otherwise, always try and maintain oxygen saturation more than 90%. Uh, so as I said, possible exception of continuing with the bronchoscopy if the patient is desaturating would be if the patient got atelectasis, lobar or lung collapse, excess secretions, hemoptysis. And as a matter of fact, bronchoscopy can be a life-saving procedure. In such difficult situations, bronchoscopy should be done by the most experienced operator. Coming to ventilatory parameters, in pressure control mode of ventilation, the peak pressure is adjusted to compensate for the elevated air resistance and maintain the tidal volume. So you can use any of the mode. You can use pressure control mode or volume control mode. But if you're using a pressure control mode, then you have to adjust peak pressures a little higher so that patient does not hyperventilate. Whereas in volume control mode of ventilation, you would set the alarm limits for the peak airway pressure higher. Okay. Again, to maintain adequate ventilation. Otherwise, as the scope goes in, the patient would start hyperventilating because the peak airway pressure would go up. So you can allow your peak airway pressures to go higher, maybe 50s, maybe into 60s, right? So long as your plateau pressure is not high, you don't have to worry too much because then the risk of pneumothorax would not be there. PEEP is a little controversial. It is reduced to zero during bronchoscopy because the peak airway pressure can increase by as much as 25 millimeter of mercury. If the disclosure PEEP is not feasible, then reduce PEEP by 50%. So here what I do if the patients are of ARDA where the PEEP is say around 10, I don't fiddle with PEEP so much. But if the PEEP is as high as 16 or 20, which is extremely rare, then I would like to reduce it to less than to maybe 10 and 12, then do it. But in patient COPD, I would keep the PEEP zero because these patients, especially they got a emphysema. Uh, if the PEEP goes as high as 25, the auto PEEP so-called goes as high as 15 or 20, there is a risk of pneumothorax. So in COPD patients, I generally put the PEEP to zero, but in ARDS patient, I don't fiddle with the PEEP much, as a matter of fact. So that's my practice. Coming to procedure, position of the bronchoscopy, the bronchos should ideally stand at the head of the patient. This allows easy navigation and understanding of the anatomy of the tracheal bronchial tree. But in Western countries, some of the bronchoscopists, do the bronchoscopy from the front. But it depends upon your training and practice. A catheter mount is important, which has a rubber diaphragm with a central orifice, especially if the patient on an endotracheal tube or you're using an airway conduit. And this allows a tight seal around the bronchoscope, and that would minimize the loss of tidal volume. And these catheter mounts are now easily available. This is what a catheter mount looks like. All of you have seen there is a diaphragm, and through which the scope is passed, and at the same time the patient is getting ventilated. This is what it is. The civil adapter or catheter mount, they are the same, and that allows the access of the bronchoscope into the airway. Then bite block has to be used, which prevents the injury to the bronchoscope by biting the bite from the patient. Lubrication of the scope is important, and the bronchoscope should be adequately lubricated prior to insertion using a thin layer of KY jelly ideally, but as it is not widely available, you can use 2% jelly, but don't use too much of lignocaine jelly because it sometimes causes dryness and then the bronchoscope can get stuck. So many times what we do, we just lubricate with a normal saline, right? Especially if the patient is on ventilator or we're passing the scope through an airway like endotracheal tube or tracheostomy. But otherwise, 2% is good enough, but don't overuse 2%. And sometimes you can also use normal saline for lubrication. Anesthesia protocol is spray as you go. So dictum is that you go behind your anesthesia, you always stay behind your anesthesia. This is an important exam in bronchoscopy. We use 1% topical lignocaine, so 2%, 1% is not available. The 2% is available, so it's about 20 ml in a vial. So we add 20 ml of saline, so it becomes 1%. The 1% is as good as 2%. So we can minimize the dose of lignocaine, especially in critically ill patients where the toxin lignocaine could be a little higher. So we don't instill too much of topical lidocaine. One couple of aliquots of 2 to 3 ml at vocal cords, then a couple of aliquots in the trachea, then one in the carina, and then couple of aliquots of 2 to 3 ml on both the main bronchi and then distally. So we generally don't use 20 to 25 ml of more than 20 to 25 ml of 1% lignocaine solution. So that limits the dose of lignocaine appropriately. Dose is up to 8.2 milligram per kg and dose the maximum safe dose by British Society, but this amount is rarely necessary. Conventional bronchoscope, conventional proposed maximum limits vary from 4 to 5 milligram, and we generally limit we generally use a limit of 5 milligram per kg of 1% lidocaine. So important thing is try to use as low dose of lidocaine, especially the patient with liver and cardiac disease and renal disease. So somebody with CKD or liver failure, the toxicity of lidocaine jelly could be high. The topical lidocaine could be high. When you introduce scope, always examine the normal lung first, right? To which you decide on the basis of the imaging. Just have a quick look at the normal lung and then go to the abnormal side where you're suspecting a pathology. Always use short runs. Okay, so just go in, right? Try to do the procedure as quickly as possible, come out. That should be the idea, right? Do not keep the scope too long in the patient's airways, right? So, and as soon as you have got you've done your job, it's better to come out as quickly as possible. So do not spend too much of time while doing a bronchoscopy in critically ill patients. So what you can do is you can do the procedure, say done stethoscope, work there for 2 to 3 minutes or 4 minutes or 5 minutes, then you give a break, allow the patient to stabilize, allow the patient to ventilate appropriately, and then go in. So this is how you do it rather than keep the scope there for hours together. That should be avoided. Always use judicial suction, right? This continuously suctioning while putting the scope inside is not advisable because that will cause a lot of atelectasis, loss of tidal volume. So only judicial brief suction should be used while doing a bronchoscopy. Coming to bronchial lavage, this is something that you would normally do while doing a bronchoscopy. That will be your main objective. Important thing is to perform BAL before any other planned bronchoscopy procedure to avoid specimen contamination. Okay. And it's always better to avoid suctioning prior to the obtaining the BAL specimen. So you're going through the trachea and through the mouth. At that time, it's better to avoid suctioning as much as possible because otherwise your bronchoscope may get contaminated. But if the malignancy is suspected, then usually done after biopsy or brushing has been done to increase the cellular content of the BAL. But generally, BAL is the first procedure that you would do while doing a bronchoscopy. The site of BAL is chosen on the basis of the radiological findings. So target the involved segment. If there is a focal disease, say there is a pneumonia in the right lower lobe or posterior segment right lower lobe, then you wedge your scope in the posterior basal segment right lower lobe and take a lavage. Always prefer sampling from the dependent segment. So you've got a lesion both in the right upper lobe and right lower lobe, you prefer to take the BAL from the lower lobe because then your yield is likely to be better. And the most preferred side would be right middle lobe and lingula if there is a patient who's got a bilateral diffuse disease, because here the lung volume is small, so you're likely to get a good yield. Okay, so you've got a localized disease, then you go to the focal area of your interest. If you've got a diffuse disease, you try and lavage from the right middle lobe and lingula. Next step is the wedging the scope. So once you have chosen your segment, then advance the scope until it is wedged in a desired subsegmental bronchus. Avoid any kind of bronchial trauma, so you have to be very gentle. Bronchoscope should always be in the center of the airway lumen and not against the wall, right? Otherwise, there'll be a lot of contamination and mucosal injury, and your sampling will not be adequate. So this is how the scope is passed. It is in the center of the lumen, and then it is wedged. Now, it's very important the saline should be at room temperature. Do not put a saline which is in the fridge, okay? So normal room temperature saline has to be there. Infuse small electrodes of 20 to 60 ml each with a syringe, observing the flow of saline at the distal tip of the bronchoscope. So you can start with 20 ml and instill 4 to 5 aliquots and then apply the suction. Okay. So keep the position of the bronchoscope wedged. Avoid any trumpet playing. So do not do frequent suctioning, as I always said. Apply a gentle suction, 50 to 80 millimeters of mercury, but while applying suction, it's always important to see that the airway wall is not collapsing. So it may be 50, it may be 80, but make sure that while you're applying a suction, the airway wall is not collapsing. Otherwise, you won't be able to collect the lavage specimen. And you should observe the flow of bubbles returning from the airway space. So when you do a suctioning, you actually find the airway bubbles, being sucked by the bronchoscope. So you have to repeat these steps 3 or 4 times. Usually a lavage of 120 ml is good enough. And maybe to 40-60 ml, yeah, out of the 100 to 120 ml that you instill is generally good enough. The first aliquot, the recovery is the least, maybe less than 20%, but in subsequent aliquots, the recovery may be 40 to 70% of the volume that you've instilled. All the aliquots should usually be pooled together. People say that you can exclude the first aliquot, but we generally don't do it. We send whatever material is there. Acknowledge an inadequate sample if the less than 30% of the instilled volume is, obtained, and the bowel fluid contains 2% columnar epithelial cells. So these are the considered to be inadequate sample. Avoid subsequent installation if there is more than 100 cc of fluid remains to be recovered. That is extremely important, especially the patient got ARDS. So if patient has got 100 ml of fluid which is within the lungs that has not been sucked out, it's better to abandon the procedure at that point of time. So while instilling this solution, the saline, instruct the patient to inhale and exhale deeply, which may help improve the return of the specimen. Higher liquids and higher total volume can occasionally be used up to 300 ml, but generally it is avoided. So 100 to 150 ml is the largest, the maximum amount that I would suggest you to instill in the bronchial tree, and 300 ml may be too huge. Manipulate the tip of the bronchoscope if there is inadequate recovery. Okay. And important thing is the wall of the bronchi should not be collapsed. That is extremely important. Otherwise, recovery would be inadequate. Some useful tips: make sure the lubricant for bronchoscopy is gently slipped in and kept as straight as possible during the exertion, and manipulate the tip only when it is well clear of the distal end of the endotracheal tubes. So you're passing through a rigid, almost a rigid tube, okay? And if you're trying to, bend the tip of the scope while passing through the endotracheal tube, then, your bronchoscope may get damaged. So it has to go as smoothly as possible, like a rice tube, okay? And once the tip of the bronchoscope is clear of the edge of the endotracheal tube, then, bend the tip of the bronchoscope. Sometimes, the bronchoscope can get stuck due to various reasons like dried up secretions, kinks in the tube, and bite of the patient. Importantly, the force must never be applied to push or pull the bronchoscope out. If there are dried up secretions, you can instill some 2 to 3 ml of saline in the endotracheal tube by the side of the bronchoscope. Look for any kinks in the tube and enhance the sedation, maybe paralyze this patient if you're suspecting there's a bite of the patient. And in case you're not able to remove your bronchoscope, there's always better that you remove the bronchoscope and the endotracheal tube together and reintubate. Okay, never allow any force because that can damage the bronchoscope. This is what I have said. Monitoring is extremely important. Monitor pulse or the SpO2 by continuous pulse oximetry. Monitor exhale tidal volume because of the potential loss of tidal volume around the swivel and through the suctioning. Monitoring pulse and blood pressure is extremely important. If you have the facility, the end-tidal CO2 should also be monitored, especially if the patient got a COPD with type 2 respiratory failure. Intraocular pressure monitoring may be required if the patient has got a head injury. During bronchoscopy, if there is a tachycardia, rise in blood pressure, or desaturation occurs, the procedure must be temporarily stopped and reinstituted after return to stable voice. So as I said, you do the procedure in not in one go, right? You give the break, okay? Short runs, that is important. Post-procedure instructions: assess for any bronchospasm by auscultation. Look at the ventilator for any, compliance or, increase airway pressures. Always check the position of the endotracheal tube at the end of the procedure. So in fact, when you withdraw the bronchoscope, you should be looking at the position of the endotracheal tube. Okay, that's important when you're withdrawing the bronchoscope from the endotracheal tube. Chest X-ray after procedure to document intrathoracic complication generally is not indicated, but if you have taken a transbronchial biopsy, then X-ray would be required. Continue vital and ventilator monitoring till the patient is stabilized, which could be 15 minutes, which could be 1 hour, but that has to be done till the patient becomes stable. So as far as the British guidelines are concerned, patients should be monitored post-procedure for complications, including pneumothorax, even when a biopsy has not been taken. So that could be a clinical judgment as well. So after the procedure, the patient desaturates or becomes hemodynamic unstable. It's always better to do a chest X-ray to rule out any pneumothorax. Coming to the bronchoscopic specimens, as I said, in immunocompromised patient, if there is a pneumonia like AIDS, the diagnostic yield of BAL for pneumocystis carinii could be as close to 100%, and other pathology is 60 to 85%. And I said these patients would have polymicrobial pathology, and in these cases, it becomes very useful. In other immunocompromised patients, the yield of BAL for infectious disease was found to be around 66%, which is again a very high yield. So this is a patient where you can see there is a bilateral pneumonia who has got a HIV. And here you can see the bilateral patchy ground glassing, then some small cystic spaces are there, interstitial pneumonia is there. And in this case, the pneumocystis carinii was positive. Okay. You can see these cysts, which was seen in the stains. Then this patient has got again a bilateral pneumonia. The CT scan showed these nodules with ground glassing, and there is a breakdown within this nodule, crescent sign, what you call. And this patient had aspergillus proven on the biopsy, and also on the culture we can see these fungal hyphae which are seen. This patient presented with acute respiratory distress, hemoptysis, and you can see bilateral ground glassing and consolidation like this, and bronchial lavage showed hemocytin-laden macrophages. Tuberculosis can be diagnosed. You can find these kind of sick patient tuberculosis coming to you with bilateral pneumonias, and here the bronchial lavage showed the acid-fast bacilli. Then nocardia, which you can see the filamentous acid-fast bacilli, right? So that can also be diagnosed with bronchial lavage. In one of the patients, we could diagnose the strongyloidosis in the bronchial lavage, and microfilaria was also seen in one of our patients who presented with pneumonia. That was way back around 30 years, and we published that case. Then this is something which is important. Should we do a bronchoscopy in every patient for microbiological sampling? So if you look at, if you're taking just endotracheal aspirate, then and if you're using the bacteriological threshold by doing semi-quantitative, quantitative cultures, then you can see the sensitivity of endotracheal aspirate, BAL, and PSB samples remains almost the same, 40 to 90% to say. And the specificity also doesn't change much. So as a matter of fact, endotracheal aspirate, the ET aspirate is majority of the time is good enough. You're doing a quantitative or semi-quantitative cultures. The bronchial lavage may not be recommended in all the patients. Coming to PSB, which is not taken up much because of the cost involved. It could be more specific than sensitive for presence of pneumonia, and a positive result greatly increases the likelihood of pneumonia being present. The quality of PSB sample is difficult to measure, and the reproducibility is also not exact. So there are some of the the drawbacks of PSB, one cost, and other, again, it has not been proven to increase the diagnostic yield as a matter of fact. So it's not being practiced widely as a matter of fact. Coming to complications, bronchoscopy is generally a very safe procedure. The complications are very less, and majority of the time they are manageable in experienced hands. The major complication rate could be less than 2%. And the mortality risk is extremely low, which could be as low as 0.01%. So it's a very safe procedure in the experienced hands. So first you have to be experienced to do a procedure, and then you can automatically reduce the complication rates. The complications would include respiratory depression, transient hypotension, or syncope because of pre-medication. Then there could be topical and related complications like respiratory arrest, cardiovascular collapse, and conversion, especially if patient got a chronic liver disease or chronic renal failure. Then during bronchoscopy, patient can experience laryngospasm, bronchospasm, hypoxemia, cardiac arrhythmias, hypertension, vasovagal reaction. Sometimes there could be a pneumonia and fever. But the majority time, when you stop the procedure, these complications automatically are taken care of, and you may have to maybe nebulize them a little bit, give a shot of steroids. So those kind of things may be required. And if the hypoxemia occurs, then you may have to take these patients on AMBU and ventilate for some time if the patient is already on FiO2 100%. Transbronchial biopsy is something I would not suggest you to do initially. Um, it can lead to the complication like hemorrhage and pneumothorax, which could be disastrous, as a matter of fact, in these critically ill patients. The post-bronchoscopy pneumothorax has been reported in many patients in whom transbronchial biopsy was not undertaken as well. So it is not just if you've done a transbronchial biopsy, only the pneumothorax can occur. Pneumothorax can occur otherwise also, because there is a lot of auto PEEP that develops in these patients. So if you're using a wider bore endotracheal tube, say 8 mm or 8.5 mm, then the auto PEEP would be less, and in those cases, the chance of pneumothorax may be minimized. But with a smaller tube of 7 mm or 6.5, chance of pneumothorax would be higher. So to conclude, bronchoscopy can be performed in almost all critical ill patients on ventilator with appropriate clinical indications, but should be performed by experienced bronchoscopists who are skilled in the use of this versatile instrument and can deal with potential complications. So this was a basic presentation on bronchoscopy. I haven't talked too much about the therapeutic implications because this becomes a totally different branch. Even many pulmonologists are not trained in doing those advanced procedures. So that should be left to them. But for you, I think this kind of, basic bronchoscopic procedure would serve the majority of our patients. I would say more than 90% of patients would be served by doing just a simple bronchoscopy in lavages. And that could be life-saving for these patients, as a matter of fact. Thank you very much.
Thank you, sir, for an overview on bronchoscopy in the ICU. I think that will be very useful for the young people. So, if there are any questions from the audience, please type them. Meanwhile, sir, one thing I would just like your opinion or from your experience in patients who come with ARDS, and most of the times, not most of the times, but generally one would know the etiology, pneumonia or whatever. But at times one is not, thinks that there might be some other etiology. So, in your experience, how is what is the role of transbronchial biopsy? Do you do it, and does it change the course and the management?
So in ARDS patient, when you talk of, in a frank case of ARDS, I would not do a transbronchial biopsy. But if there's something called ARDS mimics, where I may try it, like or if there's an organizing pneumonia, then I may try it. Or if you're suspecting that could be alveolar hemorrhage, right? Where it's a recent one, maybe it has come with a 1 or 2 days history of pneumonia, consolidation, ground glassing, and there is a high probability that this patient could be having alveolar hemorrhage or vasculitis. Then I will do it, because initially you won't see the hemostatic macrophages. They take around 72 hours. So if there is just of ARDS, I won't do a transbronchial biopsy. The other indication would be a patient who is immunocompromised, where they have the polymicrobial infestation, and when I'm suspecting there could be a fungal lesion, then possibly transbronchial biopsy in those cases would establish the diagnosis much better as compared to the just a lavage. So if you can show the fungal hyphae, then you know that this invasive fungal infection. Because many times when you get just the bronchial lavage, the even if it is positive, you're not very sure what it is. So in some situations, in immunocompromised host, where we can try. So when, in nutshell, if I'm suspecting there's inflammatory pneumonia, or if the patient is immunocompromised, then I would, go ahead with transbronchial biopsy in so-called ARDS patients.
Right, sir. So in ARDS mimics, it definitely helps according to you. It changes the outcome, and you get a different diagnosis, and the management changes, right, sir?
Absolutely, because majority of the time these patients may require high dose of corticosteroids, and then you need a conviction to treat them with the high dose of corticosteroids.
Right, thank you. So, and can you just tell me briefly about its role in managing massive hemoptysis?
So I think management of massive hemoptysis should be left to the pulmonologist, as a matter of fact. because they can do variety of intervention those way. They can put a blocker, they can put a glue there, and because many times the hemoptysis can increase while doing the procedure, so you should be able to do it, which be able to manage those cases at that point of time. So management hemoptysis is that you first manage the airway. So intubate these patients, so that the airway is secured, maintain their hemodynamics, try to do a CT scan imaging in this patient, maybe a thoracic aortogram, and take this patient as early as possible for bronchial artery ablation. That will be the safest thing. And once the bronchial artery ablation has been done, and if you're suspecting a pathology there, like a cavity, like a tumor mass, then you can put your scope there and take the samples, right? So that would be a better approach rather than going ahead and yourself managing a hemostatic case or massive hemoptysis. The other way around is, again, if you can localize the bleeding is occurring from the left side, you can put your scope, you can do a selective intubation in the right main bronchus sort of thing. But these are things that to be done by the experienced people. So as a matter of fact, in nutshell, I would say if the patient has got hemoptysis for intensivist, it's better to intubate and wait. Ask your pulmonologist to, for help. Do a multidisciplinary team meeting. What could be the best? Maybe bronchial artery embolization or therapeutic bronchoscopy by a pulmonologist to take care of this patient.
Right, sir. Thank you, sir, for golden words, I would say, with so much experience in bronchoscopy. And there are no questions. So with that, we can conclude, sir. Thank you very much, sir. And I
Thank you.
thank the audience for the patient hearing.
Thank you. Thank you. Thank you. Thank you.